Good afternoon. I'd like to thank you all for coming in this nice end of the afternoon to, learn a bit about what is an emerging new paradigm in urology, and is a bit related with the use of urine as a sample to assess biomarkers. Uromonitor is promoting knowledge in this field, is endorsing the sharing of clinical information amongst specialists on this, and for that purpose, Uromonitor has put together a cycle of seminars around this subject of urinary biomarkers in bladder cancer. Now, you will have the privilege to hear Professor Alfred Witjes tell you today a bit about diagnosis and follow-up of non-muscle invasive bladder cancer, including urinary biomarkers. On the 22nd of June, we will bring another reputed expert in this field, which is Dr. Ralph Wirtz. He has been working in a project called Stratifier and has been using Uromonitor and urine molecular testing as a means to identify patients which are eligible for targeted therapies against FGFR receptor. And this will take place in 22nd of June. Professor Witjes will make a second appearance in Porto because, Portugal is too big to have only one gathering event, so we decided to do this in the second pivotal city in Portugal. By 8th of September, Professor Nassen will give us some preliminary results on a clinical trial he has named Solution. And in this is an interventional trial in which a cohort of patients is followed up using urinary biomarker tests, and this will compare with the cohort followed up using conventional cystoscopy and flexible cystoscopy, and he will provide some preliminary results of this interventional trial, which he is undertaking in Denmark. And by late fall, Professor Torsten will try to bring us a vision of urinary-based biomarkers in bladder cancer, whether this will prove effective and will bring improvements in taking clinical decisions, or whether it will be more like a urology nightmare with additional factors to consider. So the entire idea is to put together a seminar cycle that will bring forward many of the potential clinical uses of Uromonitor. Many of them may be in practice in a very short term. Others, probably they will become a practice in a medium term, but the follow-up of non-muscle invasive bladder cancer, the idea of identifying patients for FGFR inhibitors, these are very emerging applications. We are undertaking studies regarding the use of Uromonitor in the follow-up of upper tract urinary tumors, which are also, improvements can be achieved there, and a few prospects exist in using a urine test also in the screening setting, particularly within the same population group as lung cancer screening. So we are having in the Champalimau Foundation here in Portugal and in Navarra University Clinical Hospital, we are undertaking 2 studies on that sense too. So urine biomarker testing for sure will have some role in urology in the future, in the short run, and maybe also in the long run. So Uromonitor, as as a sponsor of this seminar series, is an emerging test, and let me tell you a brief history of how this test was developed. So it stemmed from a very original and unexpected discovery that a specific mutation, 2 specific mutations, by the way, occur in a gene which is called telomerase. Urologists may have heard about telomerase a few years ago. It was pretty well known that telomerase activity was increased in bladder cancer, but nobody knew exactly how, which was the mechanism by which telomerase was activated. Telomerase is actually an enzyme that maintains the limitless replicative capability of cells. It's an hallmark of cancer. Every cancer cell needs to establish limitless division potential, and it does so by interfering with telomerase. It was unexpected that it was only by 2013, 13 years after we have sequenced the human genome, that we have found the mutations that activate telomerase. And this was because they were kind of hidden in the regions of the DNA, which we previously considered as, something that didn't actually translate into a biological activity because they didn't translate a component of a protein, an amino acid in a protein. They were more regulatory regions, and it was unexpected to find mutations there. So after this seminal finding, which really proved this biomarker to be a game changer because it occurred in over 80% of urothelial bladder cancers. So this really constituted a fantastic biomarker. The best thing we had up to that date was FGFR mutations, which were also prevalent in the range of 30 to 60%. And so putting the 2 together enabled us to really reach, for the first time, a test with, clinically useful sensitivity and specificity. The issue was that these mutations were detected in tissue, and then we had to move it to the urine type of sample, which is very different because in tissue, tumor cells are there, it's a biopsy, it's very rich in tumor. The liquid biopsy, which in the urology setting we could consider urine, the liquid biopsy is much more challenging because these cells are diluted, and these abnormal cells, they are mixed with normal cells from the remaining bladder. So we had to become very sensitive persons, and we developed specific chemistry to develop a real-time PCR assay that is able to detect 7 aberrant molecules when they are mixed with 1,000 normal ones. Actually, this then became, a test that is nowadays known by everyone. It's with the COVID-19 pandemic. There's no one that doesn't really know what a real-time PCR is, and this has made it possible that the platforms to conduct the test are available throughout hospitals throughout the world. This was patented in over 30 countries, including the European countries, United States, China, Brazil, Canada, India, Russia, Australia, and Japan. And the next achievement that was relevant to the performance of the test was to really find an alternative to the logistics of the urine sample, because it's not really easy to work with urine flasks, which is a liquid, heavy and large sample. To deal with this, we established a specific filter which is embedded with substances that make this safe due to inactivation of microbiological growth, and this also incorporates substances that stabilize the DNA in the sample, and it actually generated a very simple procedure which you can look at in this YouTube link. If you want, we can go take a peek to this. So the filtration kit is very simple in terms of components. It will give you instructions, a syringe, and these filters, which are previously treated as I have mentioned. You can run the test in as little as 5 ml of urine, but 10 ml is the standard protocol. You may get urine into the syringe, attach the filter, and then make the cells in urine go through the filter, and these cells are retained in the filter. And then you can, transform this urine sample into a filter sample. The filters can be shipped at room temperature. They are stable for weeks at room temperature, and this really allows a very practical logistics. Every nurse in your office is able to do this. This will then render the sample amenable for transport into a central laboratory where the test is then conducted on the material which is extracted from this filter. Okay. So this really was a gateway to make it easy for the test to be used in the market. And another achievement of the project was, the incorporation of a startup, which I need to say was a patient-empowered initiative. This was because, the company really was promoted by an investor, which is someone that in his lifetime had bladder cancer, got interested into these developments, and has decided to leverage the development of this product into the clinic. This is not very common, but it helps to show that there's a lot of passion in the team that is taking this to the clinic. The next step were validation trials in clinical studies. This was undertaken in reference centers, in multi-center studies. It will be most probably addressed by Professor Witjes, so I'll not get into much more details rather than stating that clinical studies have demonstrated a very high sensitivity and specificity, and for histologically confirmed lesions, the test has may reach 100% negative predictive value, which is, clinical performance with a lot of interest. We got CE marking for in connection with the regulatory authorities to make this an IVD kit, which is available for laboratories. And then the next step was the establishment of partnerships in order to take this throughout the world. In Portugal, our elected partner are the Germano Sousa laboratories, which actually are here today with us. They are probably very well known of the urology specialty in Portugal, and the test may be performed through the Germano Sousa laboratories, through its network. If his network doesn't reach you in any way, you can contact us directly, and we will make sure the test is performed to your convenience. We are now making the test available in all these countries: Portugal, Spain, Netherlands, Denmark, Germany, Brazil, South Africa, and we have distributors in another 15 countries. I think the most challenging recent achievement was the way we decided to look at this pandemic more like an opportunity and less like a threat. And so our reaction to it was to develop a filtration kit that can be performed at home by the patient itself, and this in a time where patients are, have some difficulties in feeling safe at the hospital, or in which hospitals are having limitations into accepting patients. The availability of a home kit makes it more. It was our strategy to deal with the pandemic situation. And these are the highlights of the Uromonitor project. And I hope this is a brief history, but in the long run, we will be known for making history. Thank you very much. We will take questions only at the end. And I would now change the focus to Professor Campos Pinheiro, which will host this seminar of Professor Witjes. Thank you very much. We will continue this with Professor Campos Pinheiro. Thank you.
So, thank you, Hugo. And first of all, I would say thank you for being the genius behind all this project, you and your colleagues. And thank you to David Caldeira as give us the opportunity to know this wonderful hotel, and as a very altruistic person has invested many time and many money on this project of Uromonitor. So thank you very much. And it's a pleasure to see here Professor Germano Sousa, which is a leader in diagnostics in Portugal, and he feels the good project. So if he has Uromonitor, for sure that this project has a great future. So thank you everybody, and I would like to welcome all of you and welcome Professor Witjes, which is a very known international urologist, very known in Portugal. You have been here several times, and you are known. One of your subjects is bladder cancer, so probably you are the person to give an insight of this project. But well, for years that you are looking for a biomarker that make cystoscopy obsolete, and we never found it for any reasons, because of low specificity, low sensibility. But now maybe with the results that we already have, with a very high specificity, very high sensibility, and most importantly, a very high negative predictive value, which should mean that if the test is negative, the probability of not having bladder cancer is very, very high. So probably, maybe now we have the test, and there are other tests with claiming similar results. So that would be the task for Professor Witjes, is to say, to repeat the words of Mark Twain or not, if the news of the death of the cystoscopy are a little bit exaggerated, or if we can already sign the death penalty for the cystoscopy. So please have the floor for you and try to tell us which is the point now.
Okay, thank you. I don't hope there is a death penalty for cystoscopy. That would not be nice. But anyway, so David, Hugo, thank you very much for the invitation. Sorry for being late, KLM, you're always late. I'll talk a little bit about bladder cancer. Some of you are urologists and some are, I guess, from the lab. So if there are questions, I don't mind if you ask them now. If that's allowed, Hugo. Okay. And I already knew for a long time you're a sensible person or sensitive person. So you see that looking at urine for diagnosis was already done for ages, because of course initially it was when there was blood in the urine, hematuria, there was suspicion of having something there, bladder cancer, stones in the Middle Ages. So I have some conflicts of interest, but they're not really relevant for this lecture. I'll also talk a little bit about diagnosis and a little bit about therapy, and then of course follow up, because that's the subject of today. So for diagnosis, we have history, hematuria. 90% of patients with bladder cancer have hematuria. Then we do cystoscopy, cytology, and imaging. That's the things we do normally to diagnose bladder cancer. Cystoscopy. And you already see it's not very convenient. We do miss lesions. And I now tell patients, and I'll come to that at the end again, I do a urinary test. I think the negative predictive value of the current urinary tests is better than what we see with our eye. And although I'm a urologist and I have 30 years of experience, we do miss a lot. I'll show you that in a moment. This was, for example, on the top, an EORTC study, European Organization for Research and Treatment of Cancer. I've been chairman of the bladder cancer group, where we looked at recurrences at 3 months. And that was up to 45%. And believe me, sometimes you leave tumors behind, and sometimes you miss something, but it's not all recurrences. So I guess most of that 45% were tumors you missed during the TOR. And I've done studies with blue light, where we use white light and blue light. And there you see that white light misses a lot of lesions. White light misses a lot of carcinoma in situ. And that's why, for example, urologists do a re-TOR. So they do one TOR. After 4 weeks, do a second TOR, because they leave 2 tumors behind. Imagine that in breast cancer, you take out the breast, you take off a breast, and you have to say, well, I have to operate you again in 4 weeks because I probably left something behind. You would be out of business within 1 week. In bladder cancer, we accept that. That's funny, eh? If you don't see well with hematuria, one tip, I just was in New Orleans this weekend, where I gave a lecture on this also. I sometimes do air cystoscopy. I just fill the bladder with air, so you don't have any problems with looking through all that stuff on the left side, because you can't look through bloody urine. That's impossible. With air, no problem. Just something to keep in mind. How can we improve our sights? I'm going to test your sight. I am sure that all of you will think that square A is dark gray and square B is light gray. Okay? No, it's exactly the same. Once again, A and B That's because of the shadow there. They're exactly the same. So we can't see very well. We are subjective. That's why we need a little bit more. And for that, we use, for example, blue light. And if you look at the European Urology guideline, it is said that you have to improve tumor visualization, for example, with blue light. I'm not going to go into much detail, but some of you probably will use that. And I'll show you. This is what we normally see in the bladder. Yeah. Probably there is tumor there, I guess. I think there above, I think that's tumor. The rest, I don't know. Using blue light, it's getting much more clear. You see very clear that all the pink stuff is tumor, the rest is or normal or blood. Here another example, and I really would have thought this is normal. If you turn to blue light, you see there is a large spot of carcinoma in situ. Carcinoma in situ, high-grade tumor. You don't want to miss that. You would have missed that with blue light. And here's something you do on surgery. Well, nothing. And if you turn to blue light, you suddenly see it's not as good as on the monitor, I guess. You see there are small spots of pink. That one I missed. In this lady, I think I missed around 10 small lesions. And then if I wouldn't have used blue light there, you see something, I guess, but with blue light it's much clearer. There you see, well, if you look at the monitor on the laptop, you see a better color contrast. Now you're looking at the bleeding. Wow, I have to do something with the bleeding. Ooh, I missed 2 small tumors. So you really can improve your diagnosis with looking better, or in this case, using blue light. Here the same. You missed one. And of course it's getting easier and easier because you really now know that you have to see something that we missed with white light. But I took around 20 small tumors out of her bladder, and then with blue light another 10. And here you see I already did something there, but the edge is still not normal. So you can really improve just seeing that and improve therapy with blue light. I'm going to try to get the next slide. Maybe we should do that somewhere else. So cystoscopy, okay, but can be improved. Cytology, we already used that for ages. Not very sensitive, certainly not for low-grade tumors. Specificity is okay, but cytology really has a lot of limitations. So that's not something you'd like to use. And the third thing is imaging. We always use pictures or something like that. This is from a masterclass on bladder cancer we had a month ago, which I chaired. Professor Panebianco is a radiologist from Rome. She's very well acquainted with bladder cancer. And her advice was, well, you can use ultrasound when applicable. So if you see a tumor on ultrasound, you can skip cystoscopy. MRI is something you could use to differentiate between invasive and non-invasive tumors. It's a very good way of looking at that. For the upper urinary tract, Hugo mentioned already that it's very difficult to see tumors in the upper urinary tract. You can use CT or PET. In the case of muscle invasive bladder cancer, you can use everything for staging from the notes, but again, MRI has some advantages. So that's imaging. You see the VRADS system, just like we have the PRADS system for prostate, we have the VRADS system for vesicle, for the bladder, which helps you differentiate between a small tumor and a very large tumor. And here you see some examples on the left side. There is something only in the mucosa, the bladder wall is okay, and you see it's really growing outside the bladder. So MRI also helps you in your diagnosis. If allowed, if there are questions on diagnosis, I'm fine with that. If not, I'll go on. No questions. Treatment. Just short, because I think that's all know, based on risk groups. Because low-risk tumors have a totally different outcome and prognosis as compared to high-risk non-muscle invasive bladder cancer. From almost no progression to maybe 20-30% progression, and that's a huge difference. So we use risk groups. EAU has nice classifications for that. This is the last classification. I'm not really very happy with that. It's very complicated. It's all kinds of factors, but if you want to do that, it's even online. There is an app for that. Okay, so there is something that you can use to differentiate low risk, intermediate, high, and very high risk. Very high risk is really people that actually you should advise to take out the bladder. And treatment, initial treatment is do a good TUR. Make sure that you take out what I just showed you, everything, and don't leave the half of that behind. And then initial therapy, if you have a low risk patient, you can give one installation of chemotherapy, usually on the same day of the operation. If you have an intermediate risk patient, you give a course of chemotherapy, usually let's say 6 months or 1 year, with some intervals, or chemotherapy or BCG. If you have a high risk tumor, it is really 3 years of BCG, full dose. And that's of course a lot, 3 years of installations. And in very high risk patients, actually because the risk of progression and death is really big, probably you should advise a cystectomy. I've been to the AUA this weekend, and there's a lot in that highest risk group. Of course, there are a lot of people that don't want to take out the bladder or not fit to have bladder operations. Average age of bladder cancer in the Netherlands is 73. So I see just as many patients from 80 as they are 65. And an 80-year-old guy, bladder operation, that's something. So there were really nice talks about new developments, vaccines, chemohypothermia, combination of chemotherapy, PD-L1 antagonists. Those are the new drugs that are used for invasive bladder cancer, lung cancer, and skin cancer. And there's a very nice new stuff, the Quill study they showed. There was a state-of-the-art lecture there, or a rapid abstract. They showed very, very nice results. I'll just very rapidly go over that. Currently, the state-of-the-art in the US, where they don't have a lot of BCG, there is a BCG problem, is the combination of gemcitabine and docetaxel. Those are 2 drugs we use for invasive bladder cancer also. And some smart guys thought, well, let's put it in a bladder, and it works. And they had the 5-year follow-up of their studies, and it really showed very nice results. It's not registered. It's not something that is in a guideline, but keep in mind, if you really have a patient that is not BCG reacting, so he is not responsive to BCG, he doesn't want to have a cystectomy, this might be a very good idea. Then there is, of course, what we do in the Netherlands already for 20 years, so I'm absolutely biased, and there are not many places where they have chemohypothermia. We have that. So we heat the bladder to 42 degrees and give mitomycin C, and it goes very well. But again, not many people have that. Then we have the new PD-L1 antagonist, pembrolizumab. That's the one that has been now registered in the US for BCG refractory patients. But you see that actually only very few patients have a complete response after 1 year. So the discussions this weekend were clear. Actually, nobody uses that in the United States. It's not registered or accepted in Europe, by the way. Then there is a gene, it's an adenovirus vector, which you put in the bladder, and it actually sort of promotes the cells in the bladder to synthesize interferon alpha-2b. And it's only 1 installation per 3 months, and you give it for 1 year, so it's 5 installations. So for urologists, that's very convenient. And also their responses are quite well, and currently it's at the FDA for recognition. So maybe this is really something that will come to Europe. I don't know, but might be. And last but not least, any questions on treatment? You do something else, you do nothing. You just listen. That's great. Actually, that would be a very good idea because you have more mutations in earlier stages. So they are now investigated in invasive bladder cancer, where it's around 20 to 30% have aberrant FGFR3, whereas in non-invasive bladder cancer it's much higher. So it would make more sense to study it there. Yeah, no, I think even more. So, yeah, I'm sure that's going to come. But of course, companies start at the end because you have very quick results. If patients are dead within 3 weeks and they live 3 weeks longer, your study is done in 6 weeks and you have your result. So that's why they start. But it's a good question, a good idea. Follow-up, the actual present talk of today. What the EAU says, if you have a low-risk tumor, you do one follow-up at month 3, and then year 1, year 2, year 3, year 4, year 5, and that's it. High-risk tumors very often, 3 months in the first year, 6 months yearly, and very funny, and really is in the guideline, intermediate risk is in between, like just see what you do. And AUA recommendations, the American recommendations are similar. So actually, nobody really knows what to do, and to be honest, the recommendations are mainly based on expert opinion, retrospective data. So the level of evidence is actually not even low, I guess non-existing. So for example, in the UK, NICE has said, well, it's bloody expensive, all those cystoscopies, we'll stop after 1 year. So that's a pure financial argument, which has caused a lot of trouble in the UK, but that's how they did it. So what do we know when you look at follow-up? That first cystoscopy at 3 months is important. If you have a recurrence there, a real recurrence, not something you left over, that's not good. So 3 months cystoscopy, yeah, okay, that's something you should do. In low-risk patients, you have some recurrences, but seldom progression. So their early diagnosis is not very essential. You could, for example, indeed wait. In high risk, yeah, that's very important because there the primary goal is find something and prevent progression. Because in case of progression, you have life-threatening disease. So there's a huge difference between low, intermediate, and high risk. And also, the follow-up should be different. Some hard data. Recurrences. This is an older EORTC calculator. And recurrences, that's quite well. You see that in high-risk patients, after 5 years, 80% have recurred. They keep on coming to your outpatients. You keep on seeing those patients, etc., etc. Those are lifelong commitments. And progression, that's without the use of BCG, used to be calculated in the worst group as 45%. Well, I think that's a bit high. It has been updated, so here that it's more in the range of around 20% progression in 5 years. But still, 20% of those patients will get an invasive tumor and need cystectomy. 1 in 5. That's not nothing. And here you see also that's a realistic number there. You see progression, 5 year, 22.8%. So around 20% progression, I think, if you treat them well, still 20% will progress. That's a realistic number. Oops, one back. Yeah, very good. And here you see more or less the same. An updated EORTC study showed after 5 years, 20%. So keep that amount in your mind, around 20% progression for those patients. And that's something you don't want to miss. How long? Well, NICE says 1 year is enough. Well, these were patients with low-grade tumors, TA low-grade. That's really the lowest of the lowest. You still see that there is a 5-year recurrence rate of around 40%. Some do progress, and even some patients die of bladder cancer with low-grade disease. So should you stop after 1 year? I don't think so. But that's the NICE recommendation. And the long-term fate, here again you see low-risk patients, 2.4% died within almost 10-year follow-up. So they're a bit innocent, but they're not completely innocent. Just keep that in mind for your follow-up. And this is very funny. Patients that have not had a recurrence for 5 years still get recurrences after that. These are studies looking at patients free of recurrence for 5 years. Look then what happens. You see that between 10 and 15% of those patients still will get the recurrence. I just saw a guy last week who was 50 years without a recurrence, came in with hematuria, and again had a large bladder tumor, although I checked him every year because he wanted that. And actually he was right. And how do we do follow-up? Cystoscopy and cytology. So actually the conclusion is, probably we do in some patients too much, the low-risk patients. I guess NICE does not do enough, the UK. Tools are actually, we have to admit it as urologists, we have to be honest, they're of low quality, and the level of evidence is extremely low. It's all expert opinion. So are urinary markers a solution? And to be honest, I spent the first 10 years of my academic life looking at all kinds of markers. The BTA stat test, the BTA track test, the NP22 set, all kinds of stuff. And they never were what I expected. This is one that might be useful, the FISH test, Eurovision. It detects aneuploidy in some chromosomes, but it's a very difficult technique and a very expensive technique. In the US, this costs around $1,500. And you see sensitivity, specificity, okay, but not really something that keeps you awake. And the same goes for the NP22 test. That's a dipstick, that's convenient. Takes around 30 minutes. We all now know these dipsticks for COVID testing. This is more or less the same. You just don't put your nose in that, but urine. But you see sensitivity, specificity is not really very good. That's not what you want to have. This is, by the way, used in the German BASF company for screening. And BASF, the A stands for aniline. That's what they use for making all kinds of stuff. And aniline causes bladder cancer. So they screen their workers. So this is a review from 10 years ago. The markers that we have a little bit higher sensitivity than cytology. Well, of course, because cytology has a very low sensitivity. Specificity is not that good, and they cannot be used to simply replace cystoscopy. That was some years ago. Can we use better imaging in follow-up? Well, you can do blue light, like I showed you in the movie, also with flexible cystoscope. Has been done in a few studies. It's not available in a lot of clinics. We tried that, but then you see something, you can't do anything. So it's possible, but I don't think it's done a lot for follow-up. And maybe you and I have NBI, narrowband imaging. That's a sort of optical tool to improve what you see in the bladder. For me, it's not really very good. I'm colorblind, so I don't really see the difference. And there is the one larger study that has looked at the result, 600 patients, and in all it doesn't really improve the detection of tumors. So looks nice, but it's more a toy than that it really improves your diagnosis. So there's really room for improvement, new markers, and then especially, I guess, in follow-up. In follow-up, it means you know your patient, and I think that's important because screening, like I told you, in Germany, one company does that. But there's not a lot of screening. You might screen heavy smokers, but then you do something well for people who don't do something wrong. So in the Netherlands, that's very controversial. It's not done. Hematuria workup, I guess, heavy urologists in a patient with hematuria would do cystoscopy. I would do so. I would probably not rely only on a test, but follow up. You know your patient, you know the history. You've seen the bladder before. That might be a good patient cohort to do a marker. And there have been, not only from the Uromonitor, but there have been recently a few markers with very promising results with the goal to reduce the follow-up cystoscopy, because we do a lot. And of course, it's non-invasive, which is a major advantage if you compare that with cystoscopy. And most of those tests are epigenetic tests. And epigenetics are factors, external factors, that switch on and off genes, and that affects how cells read genes without altering the underlying DNA sequence. And they are used in cancer development, progression, and even in therapy, like Hugo already suggested. And you have aberrant DNA methylation, histone modification, and non-coding RNA. So there are several kinds of epigenetics that you can use. And why are they important for bladder cancer? Well, the current methods, and you all know that, and if you work in the lab, the high throughput sequencing makes it much easier, much faster. The body of literature is really growing exponentially from a few 10 years ago to hundreds now. And they are very frequent in cancers, also in urological cancers, but also in bladder cancer, both in tissue and in urine. Hugo already suggested that, and that's true, both for diagnosis, prognosis, and in the future, I think, potential targets for therapy. New markers. I will discuss 5, because that's, I think, the body of markers that's currently being used. And I've done studies with 4 of them, and I was asked this week in the US to do a study with number 5, which is not still available in Europe. The bloody APOCheck test, it's also a test where you use 10 mL of urine. It has 15 proprietary DNA methylation markers, not the 15 best ones, but the 15 most complementary ones. It gives you a score between 0 and 100, and the cutoff is 60. If it's over 60, it's positive. In EUC of this test, the negative predictive value is high, certainly for non-high-grade tumors. So this is really something that could be used. Another test used in the US a lot, expert bladder cancer monitor test, 5 microRNA targets, and you put the urine in a small container, and this machinery, that's the funny thing, is available in a lot of laboratories, because you can also test infections and all kinds of stuff you can test with those kits, and they have a special kit for urine. And again, also this test does very well, and has a very good negative predictive value. Apparently, it's not accepting the next slide. Here you see negative predictive value again, very, very high, 95, 97%. Now, Hugo already showed you a small video, and I saw a little bit below you had a nice music video, which is also nice. Could have shown that too. Yeah. I've done the test with that, we've done a study with that. It's very convenient. You just have the urine, well, he showed you the video, so it's really not very difficult. Everybody could do that, even Dutch people. The preclinical part, Hugo explained it already. We started off with 2 mutations and some preclinical work that has been validated, and there was a very high sensitivity and a very high specificity, so that originally looked well. And then we did, that's the one I'm going to show you, a study in patients predicting whether they had tumor, yes or no. So it's a urine test. We performed that in patients that we know, so we're in follow-up for bladder cancer recurrence. We did that around 1.5 years in the Netherlands. And they all underwent, of course, also standard of care, cytology and cystoscopy. And you see here that the negative predictive value of the test was 95.3%, which is very good. And if you compare that to negative predictive value of cytology, that was 68%. So it's really much better. So conclusion with this high negative predictive value, so that's the patient. If the test is negative, he doesn't have a tumor, that's great, doesn't have to come. The test is really very useful. There is another test, CX Better. That's not used in Europe. They contacted me whether I would like to do a test with that. Again, negative predictive value, very high. And the ADX Better test, also used in Europe. Again, a very high non-negative predictive value. So these tests might really have impact on what we're going to do in the near future. And this is a review from this year. And if you look very well, and you know, that's what it is. Uromonitor comes out best in all aspects: sensitivity, specificity, positive predictive value, and negative predictive value. You see it's everywhere on the right side. And in this case, on the right side is being the best. So you do have a very good test in that. And you see here, proteins, microRNAs, or DNAs. They're all those epigenetic markers. Very good to make a picture. So I think the conclusion of urinary marker tests, the older ones I told about you, are not widely used anymore because of cost issues, practical aspects, insufficient sensitivity, insufficient specificity. In follow-up, a test with a high negative predictive value, certainly for high-risk tumors, may result in less cystoscopies. And like I told you, I think these tests do better than my eye. A follow-up test with high specificity will result in only a few unnecessary cystos. But remember, otherwise that patient would have come in for a cysto anyway. So, no harm done. An alternating cystoscopy with cytology with a new test could reduce the current diagnostic burden. So how did I do that in my department? And we finished the test, the study with the nucleus test the beginning of the pandemic, just before the pandemic. We were offered the test, and like you also suggested, then the board of directors of our hospital said, well, actually, we don't want patients to come in. So we started with home testing, and that actually went very well. We've done a few hundred now in the last 2 years, and patients are happy. I'm happy, so I get the result they send it from home. I get the result from the lab. I just phone them with the result. And if it's positive, they come in anyway. And if it's negative, they stay at home. And I alternate cystoscopy with a urinary test. And we looked at it from a financial point of view, and it even is cheaper. Patients don't have to stop working. Patients don't have to travel. They don't have to park. I can do something else because a telephone consultation is 2 minutes, and doing a cystoscopy is 20. So it's in all cost effective. We looked at the real cost of a cystoscopy because I need a nurse, I need a room, I need a cystoscope. The cystoscope has to be cleaned. I need myself. I do cytology. I need all kinds of stuff. And the realistic value of a cystoscopy in my department is 430 euros, which we not even get reimbursed. So a urinary test actually is a win. So practical issues, less workload, patients are happy, the test might very well be better than our eye, and macroeconomically this strategy is cheaper. Disadvantage, sometimes urologists or hospitals lose money because they don't have cystoscopy income. But if they would look further, I guess it's even worthwhile. It depends a little bit on creativity and time for other work and other income. What do patients like? I told you I did a lot of testing in the 90s of last century. So we did a study in 2000 asking patients, so what do you want, a test or do you want to see the doctor? And actually, in those days, everybody wanted to see the doctor. We thought, and we said, by the way, that seeing the doctor was 100% sensitive. I now know that's not the case. And this study has been repeated by Harry Hur and Memorial Sloan Kettering, and there also patients only accept the test if it is very, very good. And this is a study from very recent, it's from 2019, where you again see, it's a British study, that patients only accept a test when it is very good. Well, I think now we have tests that really are very good. So I guess we have to do some re-education of patients and of urologists, and that will be a main task for the coming few years. Conclusion. Starting at diagnosis, be aware of the limitations of cytology, but also cystoscopy. Imaging might be helpful. Treatment, use the guideline, and be creative. And follow up, as we do it now, actually has a very low level of evidence. Markers to replace cystos or part of cystos is an unmet need. Money, burden, COVID. And the bar for patients and urologists is high, so re-education seems in place. And for follow-up, several markers have a very high, close to 100% negative predictive value for high-grade recurrences. Well, if I miss a low-grade recurrence, bad luck, nothing, no harm done. Mind the specificity, and practical implementation is running. I know in the Netherlands that several doctors are now using that, and it looks convenient for both the doctor and the patient. And I think this was my last slide, so if there are now questions, I'm happy to answer them. It's a very good question. I'm looking currently, because I've now done the nucleus test in a few hundred patients, those patients that were positive but the cystoscopy was negative, whether they are predictive of a future recurrence. That might very well be, but for that I need a little bit longer follow-up. Because if that's the case, you could of course say, well, you probably will get a recurrence, I will see you early. So there might be a prognostic value in that or predictive value, but for most of the tests, I guess we don't know yet. Is there any information on that for the Uromonitor test? What happens with the false positives? Yeah. Yeah. And was very smart. You know, the upper urinary tract is extremely difficult to do. You can't look in. You have to take the patients in, anesthesia. You have to make pictures with. They're not reliable, and you also pick up tumors in the upper urinary tract. Like Hugo, also you have a study now on that. That's very smart because that's a very nasty disease, and you usually are too late with the diagnosis.
So how you deal with the imaging of the upper urinary tract using something like
Yeah. CT scan or MRI depends a bit on. CT is of course a lot of radiation. MRI gives actually quite a nice image of the upper urinary tract. And if I keep being in doubt, if I really have a real positive test, and I'm sure the bladder is negative, I take the patient in and I do on both sides a ureteronoscopy. So I try to get in, do urinary sampling, maybe take a biopsy. Because again, if you miss something there, that's nasty. Imaging? Well, I was trained in doing that every year in all patients. And I think in the past that was more a financial argument than a medical argument. And if you look at the guideline, low risk patients, you don't have to do that. Intermediate risk, high risk, I do it every 1 or 2 years. But I also rely a bit on testing. Now I have these tests. Maybe in the future, not yet. I'd like to have a little bit more, and you know, in the best case scenario, I will only do markers in the future, because I screen a lot of Lynch families in the Netherlands, so and they have a higher risk of bladder cancer and upper urinary tract cancer, and I used to do cytology and ultrasound. I now do a marker because I guess that's better than ultrasound and cytology. So I think there is a big place for markers in the future, but there's really need for re-education. I was on a symposium last year where there were some patients and they said, well, if I would have known that, you know, I wouldn't want to have a new cystoscope down there in the coming so many years, which I can understand.
If you have a reservoir, but you don't see, for me, in my opinion, it's not very important because I cannot operate this patient because I can see. So, this value on in this prognosis is not practice. Do you understand?
No, I don't know exactly what I sometimes, when I see a small recurrence and I know it is low grade, I don't even treat it. I leave it in. So I'm not interested in low grade recurrences. And if I miss one because I did a test and I missed a low grade recurrence, whatever, I don't mind. And I tell that my patients, and I know them, and they know me, and they know that I'm quite conservative in that, so they also don't mind. Yeah. Well, not yet, because there are not enough studies, but if you could predict your response to BCG, you know the literature probably better than I do, but there have been several studies trying to find how to predict the response to BCG, and for the time being, they failed. So there's not one test currently, and if there are tests, you know, every Also last weekend you see studies from God knows where, Japan, China, whatever, with very large markers, but that's not practical. Actually, you would have to have something like you have, or a dipstick, which can give you a clear and relatively short and cheap answer, because it's also a question of money. I'm not. Yeah. Now I do the test in both groups, realizing that if I miss a low-grade recurrence, or in the high-risk patients, every 3 months cysto, test cysto. And then of course, if it's long time good, you extend the interval. Yeah. Yeah, well, the sensitivities are not 100%. They're good, but they're not 100%. And I would not feel well if I would miss a guy with a bladder tumor because the test is negative, even if it's a low-grade one. So for primary diagnosis, I would probably always do a cysto if a patient comes in with hematuria. Screening, I don't have experience with screening. We don't do that in the Netherlands. Maybe screening is different. I guess that you can screen with a test to do yes or no cystoscopy. That's one of the things that they do in Germany, indeed. That might be an idea. I have no experience with screening. We don't screen in the Netherlands. They changed this year. If you look at the EAU guideline, they now mention markers for the first time. No, but they are in now. That's for the first year. So some of the companies I worked with were very, 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 very happy that the markers were in. And like suggesting that if a patient doesn't want a cystoscopy, it might be used, something like that. Well, that's a very good question. If you look at blue light, and blue light has randomized controlled trials, level 1 evidence, and if you look at the recommendation, the guideline, it's a grade C, so it's a low level of evidence, which I don't understand. And I think that's a little bit the conservatism of the non-muscle invasive bladder cancer guideline. I am sure with all the pressure of patients, of urologists, and of companies, this will move forward. They can't stop that. I'm also, like you, actually disappointed it's not yet in, because it's a good marker. They are good markers, they're more. I don't know that of all tests. Maybe you can comment on that for the Uromonitor test. I know that in the nucleus tests that I use, and we studied that, they're not influenced by infection, by BCG, by mitomycin C, which is an advantage. And I guess it. Like the nucleic test, you're also DNA based. I would expect that there will not be any influence of infections or mitomycin C, or you should study that because that would be a big advantage. No, which makes sense for a DNA test. Yeah. Sure. Well, two things. I guess maybe if I look at Uromonitor, you to be honest, you only have 2 or 3 studies, so that's not a lot. Although, for example, pembrolizumab, what I showed you, was accepted by the FDA. It's in the guideline based on one small phase 2 study. Now, I don't understand why. it's not used. But also you have to make a lot of noise. Patients have to make noise. Patients are more and more involved in guidelines. I have in my guideline panel a few patients, and patients are very powerful. Patients are very powerful. So you have to convince your patients that there's a good alternative. You have to convince the urologist that there's a good alternative. And when it's used more and more, it will come in a guideline. Because it's good stuff. The quality is there. It just has to be, people have to realize that. And the composition of the guideline will change the coming few years. And I hope in that respect, because it's a good guideline, but with younger people, which I guess are more open for changes. You're welcome.
Thank you for the audience, and this is a very young audience, but the discussion was very fruitful. So thank you very much to everybody, and I hope to still can have the buffet to eat something. And so thank you. It's closed the session.